Welcome back, everybody. Good afternoon. My name is Justin Mauger. I'm the Central and Eastern Washington Community Health Educator for the Washington Poison Center. I welcome you all to what I hope was I welcome you all after what I hope was a great lunch break back to the Washington Poison Center's 6th annual Overdose Awareness Series. Quick housekeeping reminder, this series runs with new speakers and topics every Tuesday throughout the month of August. We still have tickets available, so please don't hesitate to invite your colleagues, friends, neighbors, anyone you think who would appreciate the content of the series. Everybody's welcome. Additionally, as participants who are turning in, you all are muted. I can't unmute you, so please direct questions and comments to either the chat box or Q&A. I'll periodically be checking them, and we'll address them when it's possible. Finally, if you want a certificate of attendance, you'll need to take a survey that will be emailed to you from Whova, the conference platform, at the end of the series. And just briefly, thank you to our sponsors and partners who are We Work for Health Washington, the Washington State Department of Health Drug User Health Program and Teen Health Hub, as well as the Washington State Healthcare Authority. Now, the moment you've all been waiting for, let us welcome the Chief Executive Officer of the Washington Poison Center, Dr. Scot Phillips. Dr. Phillips has been board certified in internal medicine and toxicology for over 30 years. In addition to his position at the Washington Poison Center, Dr. Phillips continues to work as a hospitalist at Providence Mount Carmel Hospital in Colville, Washington. As a fellow of the American College of Physicians, the American Academy of Clinical Toxicology, and the American College of Medical Toxicology, Dr. Phillips is dedicated to ongoing education and teaching, focusing on environmental toxicology and health risk assessment. Dr. Phillips has authored over 200 articles, chapters, and abstracts, as well as several textbooks on medical toxicology. Dr. Phillips, thank you so much for sharing with us today, and I invite you to please take it away.
Okay, thank you, Justin. Let me just share the screen here. Get things up and going. How does that look on your end?
Looks great.
Okay, great. Well, thanks everybody, and welcome back after lunch. I appreciate you joining in. I will tell you that I begged Justin to shorten my introduction down a little bit. It's kind of embarrassing to hear that go on and on and on. But thank you for being here. It's an important meeting for all of us at the Poison Center. And we're really excited that we have such a great turnout this year and happy that you're with us. One of the areas that I've noticed a significant change in last year's, at least on the clinical side, is an increasing finding of substance use in older adults. And I thought it would be worth visiting this as a topic today, and we'll save some time at the end for questions, and please throw them into the chat as Justin mentioned. Well, of course, we have to think about what is the senior population and how is the population changing. And this figure from the US Census Bureau shows exactly what the census is been in the past and what it's doing. And you can say this pyramid is really changing into a pillar with the oldest ages at the top of the columns there. You'll see that our older age groups, people are living longer and living into later age. So currently there's about 62 million people that are over 65 years of age. That's about 18% of the US population. And that's projected in 30 years to increase to about 23% of the total population. So this is going to be an ever-growing group. We're going to see substance use and adverse drug effects increasing with time as the population increases. So what is the scope? Well, with that number of people, it's estimated that about 1 million people over 65 years of age live with some substance use issues. And if we look at Medicare data, we can see that substance use admissions to treatment facilities, and this was back almost a decade ago, increased from 3.4 to 7%. So how does aging impact this? Well, of course, as you get older, there's altered metabolism because of slowing of mitochondrial function and fibrosis of cells. There's increase in mood disorders. There's more cardiovascular disease, more chronic kidney disease, more chronic lung disease, and things just alter the pharmacology and the pharmacokinetics of medications, which can ultimately result in altered pharmacodynamics of medications. And that's true with substance use as well. It can change things. Well, commonly we think about opioids as a common medication. Opioids are prescribed commonly for chronic pain in the elderly, and many people in this age group need some pain relief. Commonly, you'll see patients with disabling arthritic conditions that are not candidates for surgical intervention of joint problems, and it can be quite disabling. And of course, people with cancer have pain as a very common symptom, one of the most common symptoms that cancer patients have, but also heart disease patients. And in just the general population, a lot of that is due to arthritis. But about 4 to 9% of the population have chronic opioid use that are over 65 years of age. So in the United States, that's anywhere from 2.5 to 5.5 million patients. So that's really quite a significant number. And we know that heroin use doubled in older adults between 23 and 25. Some of that is blamed on more controls of prescriptive opioids and less favor in prescribing oral opioids to patients. I know I had one patient that I personally took care of that had an insulin syringe, and every day she would use the same amount of heroin just based on how much she could get in this insulin syringe every day to treat her chronic pain. The reason for that was it's cheaper than filling her prescription that she didn't have prescription insurance for. So it's also the sad reality of what patients are faced with. But it's not just pain that we think about. Also, I'm quite struck by the number of patients with alcohol use and amphetamine use in this age group. But let's take a look at alcohol first. So about 65% of people over 65 years of age exceed daily guidelines, at least weekly. And a lot of this data is really done by Hahn and Grant, have really been the two that really looked at this studies. And Hahn's study found that 10% of people more than 65 years of age binge drink. Binge drinking is more than 5 drinks on the same occasion for men, or more than 4 drinks, standard drinks for women. So we also noticed that about a decade ago, treatment admissions for alcohol jumped dramatically by 107% in that 12-year period of time, and that's part of the Grant study. So alcohol use is really a common problem in older adults, and it is the most common problem that we see. We also have to think about use and misuse. I mentioned before the alcohol slide that amphetamine and stimulant use disorder is extremely common. It's common because people feel like they're slowing down. They might need a little boost. But I've been struck by the number of patients that have told me that they've started using stimulants at ages greater than 60 years as the first-time drug use. It's really quite surprising and shocking to me. But you can see that as they're slowing down, they want this little boost, and it sort of leads to this, I need that boost in energy to keep me going. So let's just briefly talk about use and misuse, because a lot of people misuse medications, not just illicit medications, but prescriptive medications as well. Misuse, we think about taking a drug to treat a specific ailment. May not be your drug, may not be prescribed for that ailment. They either have leftovers or a spouse's medication or a friend's medication or whatever, but that's a misuse. Abuse is when a medication is taken to elicit certain feelings. So you want to get sedated, you want to get more energy, you want to get high, you just want to escape. Those are all abuse-like uses, where misuse might be, I have a little bit of a cough, my spouse had this leftover antibiotics, I'm going to take those. That would be misuse. Or my spouse has a few leftover oxycodone and I have a headache, I'm just going to take that. That would be misuse of medication. So what about substance use in the elderly? Well, This was a study looking at over 61 million people done by Parrish. And these are Medicare beneficiaries in 2020, so more recent. And in this, they found 1.7 million beneficiaries were estimated with substance use disorders. That's about 8% that were less than 65 years of age. Those that are more than 65 years of age, it was about 2%. So that's a significant number. Overall, and these are all substances. So overall, about 77% were alcohol use. 16% were prescriptive drug use, and 10% were use of marijuana. It didn't delve into amphetamines or other illicit medications more than that. So of those, and this is because these are prescription records, is how they looked at this study. So of those in the past year who had a substance use disorder, 11% received treatment for that. And the reason for receiving treatment would be lack of motivation, financial barriers, concern about what others might think, logistical barriers like transportation, uncertainty about treatment efficacy. So it's a significant issue of getting therapy or not getting therapy and why. If you look at the beneficiaries with substance use, they're more than twice as likely in the past year to have serious psychological distress compared to those without substance use. Now, you might also flip that around and say people with substance use have more emotional disorders as well. And that would go with that. So about twice that, 44% versus 21% for those under 65 versus 14% and 4% those age greater than 65. So they're more than 3 times as likely if you're over 65 years of age to have some serious psychological distress. So suicidal ideation, which fits right in with this as well. And we'll talk about suicide issues towards the end of this presentation. But in the past year, suicidal ideation was higher in Medicare beneficiaries with substance use disorders than without. For those less than 65 and for those more than 65 years of age. And we'll talk about different issues of hopelessness, loneliness, etc. But certainly suicide is an important issue, comorbidity with psychological situations and diagnoses along with substance use. So this is also looking at some of that data in these elderly patients. And if you see here, these are the columns are less than 65 and over 65. And you can see alcohol use disorder was more common in over 65 years of age. Opioid use was less common in the elderly, as was prescriptive use. So it's kind of interesting. The one thing that really stands out between these two groups is a lot more alcohol use in over 65. And this is 46 million people. This is a large population that was looked at here. So alcohol use continues to be a major problem in elderly patients as far as substance use disorder. But all the other medications are present as well. Cocaine, methamphetamine, prescription, sedating medications, anxiolytics, tranquilizers like benzodiazepines, and non-prescription opioids, non-opioid prescriptions as well. So there's about 1 million adults over 65 years of age, and this is a study in 2018. And in 2006, there's about 2.6 million over 50 years of age with substance use disorders. And it's thought by 2030, just 5 more years, older adults will account for about 20% of the population. So you can see this scope of substance use progressing, just marching along and increasing year after year. A lot of that is going to be alcohol. So if you look at the SAMHSA data, the Substance Abuse Mental Health Services agency, which is under significant reductions right now because of funding. You'll see that most of this are males, most is alcohol, while females, it's mostly prescriptions use. Commonly, it's Caucasians. Commonly, these are baby boomers born between 46 and 64. They tend to have a higher income. They tend to live alone. They may have lost a spouse or lost a pet. Both are independent predictors. They may have been laid off or retired unexpectedly. Let's say they broke a hip and could no longer work. That would be an unexpected retirement. Or have chronic pain or some other limiting health condition, or they have a history of substance abuse or mental illness. These are all risks for chronic substance use issues. So what's the raising concern in aging population? You know, it's obviously a growing public health issue. It's under-recognized implications and impacts in most clinics. Sometimes there's screening done in clinics of older adults, but not commonly. Public health and toxicology collaboration, poison centers, clinicians, public health professionals, all have to be aligned to address this. Be aware of it, think about it, probe patients about it, because without knowing, we can't really offer much in the way of treatment. And there are treatments for alcohol use disorder and opiate use disorder and other substance uses that we can think about. A lot of this requires combinations of behavioral therapy and sometimes medication, but behavioral therapy is always a cornerstone for this. Poison center role, of course, we provide real-time toxicology guidance, data, prevention throughout the state. And this can be to clinicians, to other support staff, to patients, to legislators. So we provide guidance at many different levels on whether it's bills or whether it's individual caring. So part of what we do is understanding some of the epidemiologic trends. So we review our data on substance use prevalence and mortality, primarily among seniors. We recognize some of the unique clinical features. And if we look at our data at the Washington Poison Center, our data has been fairly stable about unintentional overdoses or intentional overdoses. The data has been fairly stable over the last 5 years. It hasn't been showing a dramatic increase, but it's much higher than you would imagine. And with this data, we can help to translate this into partnerships and intervention and sharing our data and our expertise with others who are, boots on the ground, or presentations like this where we might help to educate or outreach and to advise clinicians on how to manage these patients. So as far as the epi and the prevalence, so again, I said about 8% of people over 65 may have a substance use issue, and that's about 4.6 million people in 2023. So overdose death rates are increasing. Between 2000 and 2020, that 20-year period of time, there was almost a threefold increase in death rate from overdoses in those over 65. If you look at that per 100,000 population. So those age groups are not immune from, a lot of this was the fentanyl epidemic, but still alcohol is taking its toll as well, as is methamphetamine. But it's also an unrecognized burden. Part of this is just because we are not doing adequate history taking of individuals, particularly senior citizens. They may come in for pneumonia, they may come in for fractured hip, they may come in for surgery of some kind, and it may not be recognized that they have significant alcohol use until they start to develop withdrawal symptoms while in the hospital. But if they don't, it goes unrecognized unless someone asks and probes and tries to find out more about their social habits. So with this, there's been about a 300% increase in deaths. If you look at age-adjusted overdose death rate over 65 within two decades. Most of this is opioids, of course, related to fentanyl. Some people, like the patient I mentioned before, are really afraid of fentanyl and will stick to heroin. Of course, the problem is they don't really know what they're getting when they buy a product. And so about 1 in every 370 deaths due to overdose happens in these patients over 65 years of age. So it's really quite a significant number. So risk factors unique to older adults. We talked already a little bit about their metabolism. We talked about how drugs move through their body. We talked about the aging mitochondria, the powerhouse of the cell that becomes damaged. And we talked about inability to eliminate the medications after metabolism within the body. So many patients are taking multiple medications. Depending on their age, it can be 5 to 20 medications, depending on your age. So it's common to have these polypharmacy drug interaction issues, many of which can alter the pharmacokinetics of some important medications. Not unusual to see accidental overmedication, where older patients start to take a new medication and suddenly they become unresponsive and are brought in with unresponsiveness or found down as the diagnosis. And until you probe and do more testing and provocative challenges with certain antidotes, you don't really know what that might be. Mental health and social isolation, we talked about before, loneliness, loss of spouses or pets is a huge, huge reason for substance use, as is untreated depression, just trying to escape. And it really makes them more vulnerable to misuse of medications and to abuse later on. You know, older adults are not exempt from stigma. Older adults are less likely to disclose that they're using substances. They're from this greatest generation who wants to be strong and not show their weak sides. They don't want to admit to these types of limitations that they might have. And so they're often less likely to confide in their caregivers that they are using substances because they don't want to feel like they're a bad person. They don't see it as an illness. They see it as a behavior that is unbecoming of them. And so quite often it's difficult to get a history from older patients, I will tell you. And even when confronted with the reality, they will quite often deny that. And it just takes time and getting them into the right kind of behavioral therapy and treatment programs, which in some parts of the state are really limited. Geriatric, psychiatric facilities are almost as rare as adolescent psychiatric facilities. It's very difficult to get proper care for them. So some substances that are misused by seniors, often it's prescription drugs that have a depressing effect. These might be opiates, they might be benzodiazepines, it might be pregabalin, it might be gabapentin, it might be antihistamines like diphenhydramine, where people just say, oh, I'm having trouble sleeping, I'll just take a couple of diphenhydramine to knock me out. It's common, though, that they'll also use alcohol or cannabis. And of course, as the amount of THC is increasing in certain cannabis products, quite often they're not smoking it. They'll just take either gummies or other formulations and combine it with alcohol. And so you can see some really significant health issues in older patients with some of the high concentration THC products. But alcohol remains the most used and most misused substance confronting elderly. Over-the-counter medication misuse is also common, as I mentioned before, with the diphenhydramine, also known as Benadryl. And just for complete disclosure, I have no financial link to any pharmaceutical companies of any kind. And sometimes I will use trade names just to make a point, so people are more familiar with that if they don't know all the generic names. But it's common to misuse sleep medications, cold medications. A lot of the cold medications are sedating in nature. Some have some effects that, like some of the cough medications, can actually mimic ketamine in their effects just based on the receptors they use. Some laxatives can be a problem. Some antidiarrheal medications can be an issue. Some of the antidiarrheals have opiate-like properties, and you'll find older patients abusing high concentrations. I had one patient taking between 200 and 400 Imodium tablets daily, and her reasoning to me was that because she had chronic diarrhea. Well, she had diarrhea because she was habituated to the opiates in the Imodium, and that's really what caused her to have diarrhea. If she stopped taking it, she would get diarrhea. And so that's a common complaint that you might see. So if people are taking daily antidiarrheal medications, they need to be quizzed quite carefully about why they're doing that. Most people don't have chronic diarrhea without some significant underlying condition. So what are some of the clinical presentations and diagnostic barriers? Again, substance use often goes undetected in seniors, partly because they don't want to tell you, and partly is we don't want to ask them. That's just seems to be the way it is. We don't want to embarrass them. We don't want to make them uncomfortable. We don't want to somehow imply that they're a bad person because they're using, and they'll keep quiet. They're a very stoic generation, and they don't want to be stigmatized. And so that's actually quite common for them to do that. They often present with atypical symptoms like confusion, falls, memory issues. And this might be confused with dementia or delirium in some way. And so you have to really take a careful history and careful medication history, maybe even look at prescriptive frequency, look at the prescription drug monitoring form, the PDMP, that is available for the state of Washington to see what prescriptions they're getting and how often. That's really important. You might even need to talk to their treating providers to get some idea and see if they suspect anything. So low provider suspicion, as I mentioned, clinicians are just busy. They don't want to embarrass them, and so they don't adequately screen seniors because of this issue of implicit bias or assumptions. And limited self-reporting, fear, stigma, lack of insight really prevents them from disclosing that they're misusing. So what are some of the risks and drug interactions? Well, with the pharmacokinetic changes, the reduced kidney and liver clearance of drugs, the reduced mitochondrial function, it's common to get drug-drug interactions, drug-food interactions, and this can lead to multimorbid problems in seniors. Of course, fentanyl and CNS depressants heighten the risk of respiratory depression, and that would include combining it with things like kratom or 7-hydroxymetragenine, as well as other sedating medications like benzodiazepines or some of the other sedatives like antihistamines. And of course, alcohol. That can be a deadly combination, mixing opioids or benzodiazepines with alcohol, but that's commonly done. Just wash it down with a drink. So it's important to realize that and to consider that. So what are our care insights, our real world examples? So unintentional medication errors, about 42% of senior calls to the poison center involve accidental overdoses or incorrect dosing. So that's patients older than 60 years of age, 42% of those calls are accidental. That might be double dosing, that might be forgetting their dosing, that might be taking their entire pill minder pack all at once. That might be that they have a little dementia and they don't know what they're taking or how often they're taking it. It might be taking their pet's medication. There's all kinds of scenarios that we see. So there's also an increase in intentional exposures, increase in calls involving the suicide risk or substance misuse in seniors over the age of 60 is very common. And sometimes these intentional exposures have to do with stigma as well. And that's why stigma is really important to discuss in these patients. Just because if they feel bad about themselves, it puts them in a depressive, anxiety-laden spiral where they then try to self-medicate and things just get worse. And as far as support, the Poison Center can offer consultations to offer what are safe dosing amounts, specific antidotes, referral guidelines for patients or for clinicians who may call us. Oftentimes, it might be sort of an unusual medication withdrawal syndrome that they're seeing, and oftentimes they can run that past us and we can help them with those questions. So again, there's underdetection in older adults. Substance use data often omit or underestimated. We need to have better age-adjusted screening. Our existing tools don't capture a lot of the cognitive or psychosocial factors in senior citizens. And we really need to enhance our early warning, our education, our outreach, and to provide better trend monitoring to providers and the general public. And that's something that we certainly do with lectures like this. So for prevention and intervention strategies, obviously we need age-appropriate screening tools. As I mentioned, we need more community-based outreach like we do with our educators. We try to reach all corners of the state and we're very active about that. Naloxone, we are also very involved with naloxone training, with naloxone distribution. We're very involved with deprescribing medications. We do more to take people off medicines than to put them on medicines. And that's an important thing. And I always had that as one of my caveats in the hospital. Every day is to remove one medication from the patient's drug list if possible. That's important. But we're also very passionate, particularly our session host, Justin, has a whole Train the Trainers program for naloxone that's been validated in a scientific process. We've done this for geriatric groups for naloxone training, as well as some deprescribing practices that we've helped facilitate as well. So public health partnerships and policy, we like to link Poison Center with public health, which we do on a real-time data. We like some cross-sector collaboration, and we do this by having a direct backline for EMS providers to call us through senior services, through child protective services at DCYF, through hospitals and harm reduction groups. We provide pushes for more funding for provider education and regulatory reforms, and assist legislators in their quest to pass certain bills that would support this. Has been an important thing, and I've testified in several things related to this, including in last year's session. And so we really think that we can amplify this impact to help protect one of our most treasured resources, our seniors, through more interagency coordination and collaboration. And so we really enjoy working with other organizations to do this. Well, what about some other studies? This is mentioned the Parrish study early on. And this is important, again, to reiterate. Remember, alcohol use disorder in these patients more than 65 years of age. That's a big player. But just because the rates are less for opioid use and prescriptive drugs than in the younger group does not mean it's a problem. It's a significant problem. And also, if you look at the methamphetamine use, I mean, isn't it shocking to you that we have 0.03% of 46 million people are methamphetamine users, or 0.03% are cocaine users in greater than 60 years of age, people that have significant coronary artery disease as a general epidemiologic situation. These people are at marked increase for acute heart disease conditions. And again, if we look at this, we talked about, who's at risk. You can see here, more commonly in over 65, it's males, it's white males, it's higher incidence in Hispanic males. For under 65, unmarried, so young men have more on that. And also there's a increased risk in college graduates in older age groups. So it's an interesting breakdown when we look at this. If you look at the whys, what was the health characteristic that brought them to this? Very few things are statistically significant. Diabetes diagnosis is one. Kidney diagnosis is one. Some of the kidney diagnosis issue really has to do with dialysis. A lot of people would rather take substances and or have suicide rather than face chronic dialysis. The same is true with cancer diagnosis. It's really the same. People also at risk of people that have had a mental health condition in the last year, or psychological condition, or prior suicidal ideation. Those are really not surprising in this age group. But if you see, there's really no statistical difference between under 65 and over 65, with the exception of the diabetes, the kidney disease, and the cancer diagnosis. So treatment receipt among these people, the only difference is that those over 65 had less treatment received. So that goes to the fact that we got to do a better job screening, and that therefore can get people into treatment. Well, unintentional overdose deaths are, one of the leading causes of death in Washington. You probably heard me mention that in the introduction if you listened to that. I think if you look at this bottom figure here, you'll see the blue line is unintentional drug overdose deaths. And you see how that's skyrocketed, and it's continued up. This is a publication in 23, and the data only went to 21. But you can imagine how fentanyl impacted this. And so the unintentional rates went up dramatically. The intentional drug overdose death rates is only slowly increasing over that 20-year period of time. It's kind of interesting. But unintentional death rates, that has to do with potency, chronic conditions, but mostly potency of medications. Boy, here's a table that will just put you to sleep. So let's maybe break it down a little bit. So here again, we look at some of the statistics of intentional versus unintentional. And some of the interesting things you see are the rates in these groups. So you see a higher rate in males, older males, and in older females. You see a higher rate in African American and in American Indian, Alaska Natives as well. There's also an increased, risk in multiracial members of the community as well. If you look at the drugs, again, no surprise here. Not a lot of statistical differences, kind of all over the board. So what about elder drug dilemmas? And this is not just illicit substances. These are just all kinds of things. And if we look at medication errors, these are prescriptive medications that people make an error with. There's errors of commission that they create, or there's errors of omission that they forgot. So errors of commission, including dosing mistakes. They took a double dose. Look-alike errors. They took a medicine that looked alike. They're little white pills. They all look alike. Dispenser misuse, and this has to do with pill minders. Interactions with meds, foods, beverages, herbals, etc. Taking another person's medication, inappropriate storage, over-the-counter use for an inappropriate indication or misuse. Omission errors, you forget, you took the incorrect dose, you're not following instructions. You might say, oh, I only took half a pill because I'm not really sure how it's going to work, or, oh, I took a double dose because that single pill never works for me. Or improper timing of when you take the medication might be affected by food or time of day, or it might be a mistaken drug. So prescriptive errors, this is what we do as providers. We can have a frequency error. The more doses per day, the more errors. So if a medication needs to be prescribed 4 times a day, there's more likely that will be an error than once a day. Substitution error, this is where we're writing a prescription and our crummy handwriting substitutes and looks like nitroglycerin and it's really nitrofurantoin, or diazepam for diltiazem. Or duplication errors, we give them 2 prescriptions, you just write it on a pad and you forget. Drug interactions. Now, a lot of the electronic prescribing has really improved a lot of these prescriptive errors, made a dramatic difference in this. It also flags drug interactions. It flags whether they're another refill or not. And so that's an important thing to think about. I talked about suicide in older patients, but I want to talk about it again because it's really so common. In fact, it appears to me to be more socially acceptable to people. Some patients think of it as a viable option. They don't want to suffer. They may have seen another family member or spouse go through a very difficult medical situation, and they don't want to feel the same. And so sometimes suicide in some people can be a choice. Other times there's other risks going on, like depressive disorders or other psychological factors or disabilities, or their perception that they're burdensome or whether they belong or not. Other risks, violent methods to self-harm, male gender, prior self-harm attempts, psychiatric disorders. And I talked about these: living alone, having lost a family member, being bereaved, or losing a pet. These are all factors. So protective factors to increase resilience in older adults, good health and cognitive function. Religiousness seems to help with this because it gives them a group, support group to go to automatically. A good quality of life, able to perform ADLs, the activities of daily living, whether you can cook and clean and bathe yourself. Marital status is a protective factor, having friends and social connectedness, and of course, pets. Pets will actually reduce suicide. So suicide and lethal means, really we're talking a lot about firearms in this situation. But the second bullet point I think is important because when I'm teaching fellows and residents, I try to tell them that when you're starting a new medication on a patient, never prescribe more than a lethal amount of a certain medication. We know that more than a gram of a tricyclic antidepressant can have bad consequences. So prescribe less. They might need to get a refill in a week. But that's certainly better than them taking an entire month's supply or 2 months' supply at once. We do know that firearms are a leading method of suicide in both males and females in older age groups. We do know that certain groups, ethnic groups, have suicide at a higher rate than other groups and certainly have, unfortunately, less support. And we do know that the majority of suicide is still in males. So in Washington, this is data from 2017. It's a little older, but this just shows you suicide deaths from Department of Health statistics, you can see that 192 of this total group, or about 11 to 12%, were due to poisonings overall, where suffocation and firearms were the leading causes. And you can see with age groups, the rate of suicide and age groups by gender. You can see males, much higher rate in the purple in the top graph. Females go up in mid ages and go down as they get older. And you can see the racial groups below: the American Indian, Alaska Native, and Caucasians have the highest suicide death rates before. I show this slide because I know we're getting close here, but I show this slide because I think it's interesting to look. The darker blue, the higher the suicide rate, and these are done by death certificates. So what it's really giving you is a snapshot of rural communities. The very lightest colors, there's no data. There weren't enough to really capture the cases. But if you see in Central Washington, Northeast Washington, Southeast Washington, and the Peninsula and Southwest Washington, these are significant rural communities. That's with, of course, the exception of, Pierce and Lewis counties. Part of that might be compounded by population migration in and out because of military bases. But in general, rural areas, rural counties tend to have higher rates. And that has to do with a lot of the multiple social factors: higher smoking rates, higher depression rates, higher alcohol rates, higher smoking, et cetera, all in these rural areas. So we really need to think about a multimodal approach to medications, use and monitoring, mental health access, asking questions, survey them. 1% of all hospital admissions are for drug interactions. 15% people admitted to hospitals have at least one drug interaction. It's probably higher than that, just because not all patients are looked at, and there's probably some geographic variation there. Our clinical pharmacists in hospitals now do a terrific job in looking at medications more closely and doing more medication management. It's really very helpful. And this can be done on outpatients as well. And as you see in the bottom bullet there, there's about 1.5 million adverse drug events. And if we have pharmacy medication therapeutic monitoring, it can save the US about $500 billion by keeping people out of hospitals, by having them live a better life. So I always say, shared decision-making, phone a friend. That's really the most important thing here. And your friends can be pharmacists, can be other clinicians, can be patients, it can be families, but don't hesitate to bring this up. So in summary, it's currently increasing the use of substances and illicit drugs. Older adults are more susceptible because of their aging and metabolism. They're more likely to unintentionally misuse medications. They may take medications, misuse them as a way to cope with life changes like retirement, grief, loss, declining health, et cetera. Most admissions to substance use treatment center are for alcohol. And there's many behavioral therapies and medications that have been successful in treating substance use disorders. So there is help available: behavioral help and medication help. And of course, it's never too late to quit using substances. They just need help with therapy and medications quite often. But it has to be determined first. So our clinicians, families have to do a better job in being aware of this. But clearly more science is needed. We have to do more to think about the effects of these substances on the aging brain. A lot of our studies are really done on younger people, and our studies on older adults are ecological studies or just a large community cross-sectional studies. Oftentimes, I think providers may confuse symptoms of substance use with other symptoms of aging, such as dementia. So it's important to really think these through and analyze them really well. So with that, I'll say thank you, and I'm going to stop sharing and toss it back over to Justin.
Great, thank you too. Looks like we had a couple comments. Thank you for those. We'll take them into consideration. If you have a question for Dr. Phillips, feel free to throw it into the Q&A. I had a couple I could ask though in the meantime, and maybe it'll inspire folks to think of one as well. I was wondering when you talked about altered metabolism and changes in pharmacokinetics heighten the risk of accumulation and toxicity. I know very like broad stroke kind of overview that the first pass metabolism slows down, excretion slows down in people, and that I think can kind of lead to a higher level of the drugs in the system or the substances in a person's system. Can you just give some more detail about that process?
Yeah. So decreased metabolic capacity is whether you break the drug down or not. And so if you can't break it down as well, it tends to build a little bit more in the system. Our normal prescribing habits are based on, we know this amount of the drug is going to be eliminated over time. So if we give it this frequency, we can get this normal concentration that we want. But if your metabolism by the liver is not functioning as it should, then you're not able to break down that amount of medication and it can build up. And the same is true with excretion. Excretion essentially means eliminating from the body, and whether that's in the bile or the urine, if you have decreased ability to eliminate a medication in the urine, for example, because you have chronic kidney disease, that medication will also build up in your system. So it's really common to take these things into consideration when we're prescribing. And quite often, if this is done on an electronic medical record and electronic prescribing, these are automatically calculated for you on telling you how to dose a medication. So there's been some progress with that. But you're right, if you're older and your mitochondria aren't working and your cells aren't working as well, it'll build up and you can't get rid of it as quickly.
So should doctors, like say you're an older adult and you're prescribed 5 medications, over time, should their doctors typically be reviewing those medications and maybe considering reducing the dosage?
Yes. Yeah, that's kind of the quick answer, yes. And I think one way to think about that is that, you probably have all heard that when you go see your doctor, bring all your medications with you. Part of the problem, it's a little better now with us being able to share electronic medical records, but oftentimes there's what we call doctor shopping. They'll go from one doctor to another doctor, one hospital system to a different hospital system, and not always does a provider take time to look through that. So you really have to spend time asking each question. How many you take? Do you ever take extra? Do you always take it on time? Do you not take it as frequently? So it's really up to the provider to take that detailed history and find that out.
Great. And we had a question in the chat. I can't see the person's name, so I apologize for that. But at our poison center, many of our pediatric cannabis exposures are in the care or watch of a grandparent. Can you speak to some additional education outreach that we can do in the population? Thanks.
Yeah, sure. So we do a lot of educational outreach, and cannabis, I would say, and this is better than I do, Justin, cannabis and vaping are probably two of our more requested topics besides naloxone. And so, yeah, we go out and we talk to elderly groups, we talk to young groups, we talk to school age kids of all school age and college kids. And so it's really outreach and education and engaging the public and making them aware. And particularly with cannabis, it really has to do with the increasing content of THC that we're seeing that can be a real problem in the very young and in the very old. So it's really education. It's getting out and making people aware.
Great. And I would add in Washington State, I'm not sure what the what the practices are in other states, but some years ago, the Poison Center created a red hand that is now marked on cannabis products, typically that says "not for kids," and it's a reminder for those grandparents or for the adults that are consuming cannabis to put it away, to keep it somewhere out of reach in a safer spot. Um, Thank you for that. I also had a question about stigma. So you mentioned that stigma may prevent people from being open to discussing substance use. As an ER doctor yourself, do you have thoughts or advice on dealing with that? You mentioned speaking with patients about stigma. What's that sound like? What's that look like?
Well, when you only have a few minutes to talk to a patient, you have to be to the point, but you can't be accusatory. Um, because that just sets up a block and you're not going to get anywhere. The problem is emergency departments aren't the best place to discuss chronic medical conditions just because there's no time. There's so much going on and so many other patients to deal with that you have a small snapshot. So it's about respecting the patient. It's really about, I know you're here, you must be having a difficult time. I'm sorry, what brought you here today? How can I help you? Are you experiencing any issues? And I ask everybody, I phrase it, I ask everybody these questions: any trouble with alcohol or substances, anything you'd like to tell me? Has anyone made you feel uncomfortable about this? I mean, I just ask people and try to have a conversation and kind of reach them where they are, as opposed to starting off with, well, you smell like alcohol, so what's the problem? That just sets up the wall and the stigma and just reinforces the stigma. And I will say, Justin, you're really the stigma expert in our shop. And so do you have any other thoughts on that?
Hey, I've been a caseworker before I came to the Poison Center as a Medicaid caseworker for in-home care for about 6 years, and it's just about I think not using judgmental language. When I do a Narcan training, I ask people, and one of the advice we give is from actually one of our sponsors, the Friends for Life campaign, in their How to Talk to Teens About Fentanyl. And it's, don't be judgmental, right? I ask people who likes to feel like they're being judged, right? And like, no hands ever go up for that, because that's not, that's not where we're at. Like, we want to connect with people, understand where they're coming from, be careful about stigmatizing language, ask questions, I think, as well, like have open dialogue and be able to talk about it without feeling that I think the more you do it, the easier it gets. But sometimes when we talk about substance use with people, there can be a vibe of like a lot of pressure and a lot of anxiety around it. And being able to be more comfortable talking to people about it and really connecting with them is really where you're going to get the truth. But I can understand, or at least closer to the truth. I can understand what you're saying, like in an ER. I think also talking to my Medicaid clients in the past, oftentimes they're like 15 minutes in and out of the doctor's office. We can talk about one thing today, and it's difficult to bring up other things. So, yeah, it's a challenge. We have another question from Jody in the chat. Is there anything being done to make the vaping products unavailable? The AG's office spent billions of dollars fighting tobacco companies, getting rid of ads, etc., and now we have vaping stores in strip malls. Seems like a lot of work has been undone.
Yeah, it's true. There's a lot of issue with vaping right now, and part of it is the higher concentrations of nicotine in vapes that we're seeing a real issue with. And we're probably seeing more nicotine toxicity than we have in prior decades. I haven't looked at that recently, but we do get very frequent calls about nicotine toxicity. But it's also the reusable vapes, where people can fill them with whatever they like. And we've seen, everything, including fentanyl, added to vapes. So it has to be, very careful, how we approach this. But there's no question the business of vaping has really been growing. And I thought it was going to take a decline when Juul had their legal battles a few years ago, pre-COVID. But quite honestly, it seems like it's coming back with some force. And what we can do about it is speak up, call your legislators, testify on bills that might be prepared, or support your legislator to make a bill on this. That's probably the most important thing you can do.
Sure. Excellent. And I think that we're right at time, so we'll leave it there for today, unless you have any final thoughts you want to share.
Just want to thank everybody for joining us, and keep coming. We have several more Tuesdays in the month full of great topics, and I'm looking forward to listening to many of them myself. So Justin, thank you for guiding us today. I really appreciate that, and keep up the great work. I appreciate it.
Thank you. Thank you so much. And thanks for sharing with us. I certainly appreciate your expertise, and I always love to learn from you. So next up, we do have gas station highs, a different fuel at the pump with Dr. Leonard. That will be at 2:30. So we hope to see people there. Thank you so much for coming to this presentation. We, of course, love to see the praise in the chat box. And thanks again. Have a great day.
Bye-bye.